Thank you. Good afternoon, everyone. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation. And on behalf of NIHCM Foundation, welcome to our webinar today. While ACA open enrollment is off to a strong start, there's still widespread uncertainty and confusion regarding future market stability. The outlook for bipartisan market stabilization legislation remains unclear, and repeal of the individual mandate could impact enrollment and weaken risk pools. We're pleased to have an excellent panel of speakers with us today to explore opportunities to stabilize the individual market and provide affordable insurance options. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag ACAMarkets. I am now pleased to introduce our first speaker, Giesa, the National Practice Leader of Oliver Wyman Actuarial Consulting's healthcare practice. He's one of the authors of a recent paper on options available to stabilize the individual insurance market, and we're so pleased that he's with us today. Kurt?
Catherine, thank you for the introduction, and let people on the phone know I'm grateful for the opportunity to share some thoughts with you regarding stabilizing the non-group market. Catherine asked that I briefly describe the individual or non-group market before I get started. Kris Haltmeyer, who will be following me, will do this more thoroughly. But what we're talking about here is essentially the only option for individuals who don't have access to Medicare, Medicaid, or coverage through an employer. It doesn't represent a large segment of the under 65 population with coverage, probably less than about 10%. But it's really the only source of coverage for those who need it. So in that sense, it's an important market. I've got really 4 slides to share with you that I hope you'll find insightful. I have a slide that I hope helps explain the premium rate increases we're seeing in 2018 and the impact that a number of decisions had on those rates. In another slide, I estimate the cost of guarantee issue in the non-group ACA market and argue for an external funding source to cover that cost. And then I have a couple slides discussing the subsidy structure in the non-group market and the potential for change. So I'll start with my take on what happened with premium rates in 2018 and how we got here. This isn't meant to illustrate the extremes, but only to provide an example of how an issuer could have arrived at a relatively high or relatively low rate increase in 2018. Actuaries started thinking about 2018 premiums before 2017 data was actually available. But they had seen the results for 2016, and market-wide, premiums were about 9% short in 2016, and that followed an even larger shortfall in 2015. So the starting point for our 2018 premiums here, the rate increase, is really the 2016 premiums plus 9% to cover the 2016 shortfall. That's what I put in the first row of the table, the underpricing in 2016. Medical trends still operating in this market, and we're seeing increased use of high-cost services, more high-cost claimants. And I'd include here an anticipation that the risk pool may deteriorate. And so I made trend really 8% per year here for 16% total. We had the price for the end of the transitional reinsurance program that ended in 2016. That was worth about 5% of premium. That's just something that was sort of structural in the system that had to be covered. And now it seems like ages ago, but in February, the administration announced improved enforcement of SEPs, changes to the rules around the grace period, and an expanded de minimis range for AVs. We estimate that was about a 3% premium reduction. So if you take all those things together and add them up, you get about 27%. Now, premiums actually increased by 22% from 2016 to 2017. That's towards the bottom of the table, the effect of the actual rate increase, 2016 to 17. So we actually, of the 27%, we actually recouped about 22% with the 2017 rate increases. So if we'd stopped there, we may have only needed a 5% premium increase or going into 18, or if an insurer wasn't going to price for better enforcement of SEPs, maybe 8%, or if they were going to be conservative, maybe 10 or 12%. But, of course, we didn't stop there. Instead, we've got a lot of uncertainty regarding the enforcement of the mandate from the executive order early this in the current administration, and then the IRS saying they wouldn't enforce the mandate earlier this year. We also have lack of CSR funding and what I've termed general regulatory risk. You add all this up, and you need to increase rates. This is what I show near the bottom of the table. You need to increase rates by somewhere between 33 and 65% to get from 2016 to 18. And again, we got 22% of that with our 2017 rate increase, so that leaves something like 11 to 43%, most of which could have been avoided. This is, of course, the recent past. That's what we're talking about here. But this market's been buffeted from so many directions for such a long time. We had transitional policies under the prior administration that allowed the healthiest lives to stay out of the market. They could keep the policies they had in force. And now we have the executive order on short-term medical, which we have to deal with that. And that may also allow the healthiest lives to stay outside the single-risk pool. What this market needs more than anything right now, in my opinion, if it's going to function well, is some regulatory stability. Here's the next slide. And in this slide, I develop the cost of guarantee issue in the non-group market as being worth about $15 billion. This analysis isn't perfect. I don't really think it's possible to do this analysis perfectly, but what we've done here is we've done our best using data from the federal MLR reports to develop an estimate of the cost of guarantee issue in the 3-to-1 age rating in the non-group market. Our starting point, the first bar on the left, is the average premium in the non-group market in 2013, so before the ACA, trended forward to 2015 using the change in group premiums between 2013 and 2015. This yields the premium that I show there of $284 PMPM. Our starting point is 2013, as I said, so this includes the cost of the ACA provisions that went into place before January 1, 2013. For example, coverage of dependents to age 26. The next bar, network discounts that I show here at $31 PMPM, is something that's difficult to estimate with precision. The effect of network discounts or narrow networks on pricing, but so this is based largely on our experience and our judgment. But we used an estimate that network effects are worth about 7%, actually lowered costs by about 7%. The next bar, geography, measures the change in the distribution of business by state between 2013 and 2015. The subsidy structure makes coverage in high-cost states relatively more affordable, and we wanted to estimate that effect, but you can see here it isn't large. It's only $6 PMPM. The increase in taxes and fees of $15 or $180 per year, $115 PMPM or $180 per year, that comes from a comparison of 2013 expenses trended to 2015 compared to actual 2015 expenses. So that's a measure of how much expenses increased trying to due to regulation and things like administering the risk adjustment system in 2015. And that's $15 PMPM. A large change here is what we estimate for the cost of benefit changes. This is the increase in AVs. So, prior to the ACA, AVs were about a 0.6. Post-AV or post-ACA, the AVs in 2015 we think are about a 0.7. We also have EHBs included here, pediatric dental vision, mental health and substance abuse parity, and we estimate all these effects to be worth about $51 PMPM. The next factor, rateable demographics. This reflects the fact the market got a lot older between 2013 and 2015. Issuers could rate for that, of course. They could charge higher premiums for the older population, but only up to 3-to-1. I'll discuss this in a minute, but the 3 to 1 for age and the subsidy structure have made coverage much more attractive for an older demographic than was the case pre-ACA, and so the market's really skewed older, and that gives us a $50 PMPM for rateable demographics. Now, if you skip a bar and go to the far right, the $436 PMPM, this is the average premium in the market in 2015. And the thing that gets us here, the bar next to it, or the little bar next to it, what I've termed morbidity and unrateable demographics, you can think of this as the cost. This is the balancing item, the thing that we really can't explain. And you can think of this as the cost of the societal good, and you could put good in quote marks if you'd like, but this is the cost that policymakers put into this market when they required guarantee issue and modified community rating. You know, anybody who wants coverage has access to it, and they can't be written up if they're in poor health. This costs about $62 PMPM, or about $744 per year. This cost is actually being paid in two ways. If somebody's eligible for premium subsidies, their $744 for the year is being picked up by the taxpayer. The premium subsidies cover it. But for those who don't have a premium subsidy, they're being asked to pay this cost out of pocket. So you could really say to yourself, well, what we're doing here by requiring guarantee issue is we're asking anybody who's healthy, who wants access to the market, to pay an extra $744 to gain access, more than their real cost. A couple interesting things about this value. First, recall that the penalty is the greater of the penalty for not having coverage is the greater of 2.5% of income, or $695. I don't know if the policymakers who drafted the legislation and came up with the penalty level had some idea that the cost of guarantee issue might be about $750 PMPM, or this $744. But it's interesting to me that the penalty that you have to pay if you stay out of the market is pretty close to the cost that you have to cover if you're healthy and you want to come into the market. The second thing that I think is probably more important here is if you take the $744 per year, extend it by the size of the non-group market in 2015, and then trend it to 2019 or 2020, you get about $15 billion PMPM. And so that's my estimate of the cost of guarantee issue in this market. It's about $15 billion PMPM. We've done a lot of work with our microsimulation model. One of the things we've looked at is the effect of funding a $15 billion reinsurance pool, external funding, say federal funding for a reinsurance pool of $15 billion. And we estimate that it could lower premiums by more than 20%, bring in a number of healthier individuals. And a large majority, this is one of the sort of oddities about the way the subsidy structure works, but a large majority of this $15 billion would come back to the federal government in the form of lower APTCs, lower premium subsidies. Lower premiums mean lower premium subsidies from the federal government, so the feds would recoup a large share of that. And actually, I just note that this level of premium reduction and the kind of the return of the funding back to the feds is consistent with what Alaska was able to accomplish with their reinsurance pool. So I've really got one more concept to share with you, and this has to do with the way the subsidy structure works. And obviously on this slide I've got two charts. The chart on the left, I'll start there. We've taken a premium of $433 PMPM. That's the value that ASPE reported as the average lowest cost silver premium in 2017 in the healthcare.gov states. And we developed premium rates by age that an actuary would like to charge in the market, essentially using an age slope of about 4.8 to 1. That's sort of the underlying spread in costs by age in this market. I like to think of this, these premiums, these actuarial premiums, as really the true cost of coverage, and those are the dark blue bars in the chart on the left. That's the actuarial premium. We also developed premiums using the ACA's 3 to 1 for age. We use that slope. Those are the light bars in the chart on the left. And in this chart, the chart on the left, you can see we show premiums for age 24, 44, and 64. And we also show that the 24-year-old is paying about 37% more than their actual cost of coverage. And the 64-year-old is paying about 7% less. The 44-year-old is paying slightly less than their true cost of coverage. But this is the effect of 3 to 1 on age. It makes coverage more expensive relative to the sort of the underlying true cost for young people and less expensive for old people. Those premiums are premiums before premium subsidies. On the chart on the right side, we show the out-of-pocket cost of coverage after premium subsidies by age and by FPL. Now, FPL is along the x-axis at the bottom. Recall that at a given FPL, the amount an individual has to pay towards the cost of their coverage is the lesser of two things, the actual premium they're looking at or a fixed percentage of their income that varies only by income and not by age. So in this chart, you can see what this means. It means that at 150% FPL and at 200% FPL, the 24-year-old and the 64-year-old pay the same amount out of pocket towards the cost of coverage. At 150% FPL, it's at $720. At 200% FPL, it's the $2,400. Those are what they'd have to pay each year to gain access to coverage. But at 350% FPL and above, that's about $41,000. The 24-year-old and the 44-year-old aren't receiving premium subsidies any longer. You can see the premium they're paying. For example, for the 24-year-old, the dark blue line under the 350% FPL, they're paying a $2,613 premium. That's the premium under the ACA in the chart on the left for a 24-year-old. Same is true with the 44-year-old. They don't qualify for subsidies anymore because the percentage of their income they're asked to pay is greater than the premium that they're looking at. So what this means, you can see that the 64-year-old is still receiving a large subsidy at 350% FPL. They're paying roughly $4,000 for coverage, but the premium is $7,800. So I've got one more slide to share with you, and this is kind of another way to look at the situation. I think that a lot of the work we've done is assumes that people have some sort of an intrinsic idea of the amount of the health care they need, and what I've been calling kind of the actuarial premium or the actual cost. And I think this serves as a pretty good proxy of the relative value of coverage by age. So in other words, with a 4.8 to 1 age slope, that means the 64-year-old will place about 5 times the value on having coverage as a 21-year-old. And in this chart, we show how the actual cost of coverage after premium subsidies compares to the actuarial premium or the true underlying cost. Again, I'm showing age on the x-axis here, and the dark blue bars are for 150% FPL. The 0.38 for age 24 at 150% FPL at the far left, you can see that 0.38 there. That means that FPL, 150% FPL, the 24-year-old is paying 38% of the actual cost of the premium. If you go to the other side of the chart and look at the dark blue bar, somebody age 64, they're paying just 9% of the actuarial premium or the true cost of coverage. At 250% FPL, that's about $29,000. The 24-year-olds actually paying 126% of the premium. So this is somebody who's age 29. They're really getting no help in covering the actual cost of coverage. They're paying more than their actual cost of coverage. They're paying 26% more than their actual cost of coverage. This is due to 3 to 1 age and the fact they don't get premium subsidies at that level. While the 64-year-old, if you go to the other side and look at the light blue chart, they're only paying 28% of the actual cost of their coverage. So you can see that really at every age and every FPL, older individuals do better, and in some cases much, much better than younger individuals. I think these values are the reasons the pool is skewing older, and I understand that changing the subsidy structure is difficult politically, but until we make coverage better for younger individuals, more affordable in particular, the pool, I think, is going to continue to skew old, and the market won't be able to adequately serve that segment of the population. So I guess the question is, what does the non-group market need? And this is just my perspective, and it's really a pretty limited look. There are lots of ideas out there, but what I've put forward here, I think the market needs stability and consistency from policymakers. It needs funding to help pay for the cost of guarantee issue, some sort of external funding. It doesn't have to be a reinsurance program, but somehow we need to get premium into the market to lower the cost of coverage in this market to cover that societal good that is guarantee issue. And finally, we need a subsidy structure to encourage broad-based participation. So those were the slides I wanted to share with you, and thanks very much for your attention here.
Thank you so much, Kurt. That was a really helpful setup, and we're going to segue into our next speaker, Kris Haltmeyer, Vice President, Legislative and Regulatory Policy for the Blue Cross and Blue Shield Association in Washington, D.C. Kris oversees regulatory and policy development, working on a broad range of issues, and he joins us today to share his perspective on how to improve affordability and competition in the individual market. Kris?
Thank you, Catherine. It's great to be here with you today to share some thoughts on how to stabilize the individual market. There seems to be a certain amount of fatalism about how to fix this market in Washington, and having spent 20 years looking at policy issues surrounding the individual market, I don't think these problems are insurmountable. My message today is that we can take steps to stabilize this market that will actually reduce premiums, not just reduce the rate of growth in premiums, but substantially reduce net premiums that are actually paid by consumers. With a little political will, I think we could do this before the next open enrollment for 2019, and with only a small additional investment from the federal government. I'm having a little trouble. There we go. I'd like to start today by talking about why we need an individual market and why we can't let it fail. Next, I'd like to talk about how the market has changed since 2014 to build on some of the things that Kurt mentioned, and talk about some of the challenges the market currently faces. And I'll conclude by giving you my thoughts on how we can address these challenges. Firstly, why do we need an individual market? We need an individual market because 17 million people rely on this market today. Only half of these people obtain subsidies on exchanges. The market remains an important source of coverage for small business owners, retirees, and those who don't have access on the job to health insurance coverage, in addition to those people who are now able to purchase it because of these tax credits and subsidies available on the exchange. I think it's important that we may all rely on this market at some point in our lives, either for ourselves or for our loved ones. And that's an important reason why I think we should all have a stake in stabilizing this market. Unfortunately, the market today, there we go, is not healthy. When we look at the trends on exchanges, we can see that the number of issuers per state has declined to only 3 on average. In healthcare.gov states, we have 8 states with only 1 issuer. And premiums, for the reasons Kurt has talked about already, have increased significantly since 2014. With the changes this year, especially the changes related to CSRs, we've also seen a very significant increase in the tax credits that are paid by the federal government. What's driving this instability? I think Kurt identified some of these issues, but one of the biggest factors is the rising cost of coverage itself, which is making premiums unaffordable to middle-class consumers, including many long-term customers that have been in this market and relied on this market for years. The issue of uncertainty, certainly the debate around cost-sharing reductions this year was important, important source of uncertainty. The current debate about whether to continue the individual mandate is another. And I think there's just kind of the sense within the industry of, gee, what's next? Every year there seems to be something that results in a significant change in policy after health plans set their premiums. And I think there's just a lot of concern about the politics surrounding this law. We're also potentially going to see a return to market segmentation in the individual market. The administration has signaled through their executive order that they could allow for 364-day sale of short-term limited duration policies. These are fully underwritten plans that I think would cherry-pick the individual market. There could also be expansion of association health plans to the individual market operating under completely different rules. So those are creating some concern in the industry as we look forward to 2018 and 2019. We continue to see significant cases of providers steering high-cost patients from other programs that they might be eligible for into the individual health insurance market. And we're also seeing maybe a shift away from the federal government being a primary means of marketing coverage in this market to one where we're going to rely more on other types of distribution. So how has this market changed since 2014? Well, prior to 2014, this was an underwritten market that primarily covered people with standard risks. The market was smaller, about 11 million people, and people covered in this market were generally much less expensive, probably 70 to 80% of the cost that you would see in the group health insurance market. The fundamental change with the ACA was to allow all individuals, regardless of health status, to purchase coverage with no pre-existing condition exclusions and no rate-ups. Eliminating limits on those with pre-existing conditions, which is one of the most popular elements of the ACA, was a good thing. This fundamental change made coverage available to people who might not have had access to coverage prior to 2014 and would otherwise not been able to afford coverage. But it also came with a cost. Kurt talked a little bit about that in his slides. At the same time, the subsidies that were made available in the ACA allowed individuals who traditionally wouldn't have been able to afford coverage to purchase in this market, and those account for about half of the purchasers today. We've taken a look at data from claims data from the individual and group market to look at the risk profiles of these two markets since 2014. And I think this is an important thing to look at to really illustrate whether the individual market is in balance or getting out of balance. As this slide shows, the prevalence of high-cost conditions in the individual market is significantly higher than those in the group market. And this is based on a very large sample, 2.4 million individuals purchasing in the individual market compared to a very large sample of group coverage. So this is one illustration of how this market has deteriorated since 2014 in terms of the risk composition. When we compare the claims in the group market to the individual market, we now see that there's 17% higher in the group market after controlling, in the individual market rather, after controlling for actuarial value differences and age differences across these two markets. So this is a clear indicator that the risk pool in the individual market is out of balance today. We believe that a reasonable goal would be to bring the group and individual market costs into parity with one another. This is another way of illustrating the affordability challenge in this market. And it really shows the consequence of this increase in cost, that people are being priced out of coverage. So this chart looks at the percent of income that someone age 55 would be required to pay at various income levels in 2018. And as you can see here, someone at 400% of poverty who would not receive any tax credit would be required to pay 16% of their income to purchase coverage. This would clearly make health insurance unattractive to most people, especially if they don't have significant medical costs. So how can we stabilize this market? I think Kurt hit on one of the most important things, or probably the most important thing we can do, which is providing broad-based funding for individuals with the greatest medical needs. About $15 billion annually, and we developed this in a way that's completely independent from what Kurt just showed you, is needed to bring claims costs in the individual market in line with the employer market. We estimate, and this is a BCBSA estimate, that providing that $15 billion in funding for a high-risk coverage program would only cost about $5 billion. This represents less than 1% of the $800 billion in total federal expenditures that we currently have supporting private health insurance. And we believe that this one step would reduce premiums in the individual market by 2019 by 19%, if it could be done in a way that issuers could operationalize. And that probably means relying on something that is similar to the reinsurance program, that was available from 2014 through 2016 in the individual market. So in addition to providing broad-based funding for those with significant medical needs, we also believe that it's critical to provide a stable, predictable regulatory environment, reduce the taxes and fees that drive up health insurance premiums today. This includes the health insurance tax as well as the cost for distributing coverage through the exchanges, which has grown substantially over time because it's based on a percentage of the premium. We also think it's critical to ensure that there are powerful incentives for people to remain continuously insured. We have not been able to come up with an alternative to the individual mandate that is nearly as effective. We've looked at all sorts of different types of options for encouraging people to maintain continuous coverage. So if the individual mandate is non-enforced or eliminated, it's going to be a real challenge to ensure stability in this market. And fifthly, I think we need to avoid policies that will destabilize this market rather than providing stability for the 17 million people that I've mentioned. Allowing fully underwritten 364-day short-term policies or exempting association health plans from state regulation will actually destabilize the market rather than stabilize it. I think if we could take these 5 steps, we could reduce premiums significantly and put this market on a path towards stability. We would certainly support much of what Kurt mentioned around changing the way the tax credits work and making other changes to improve affordability so we have a more balanced risk pool. But I think these are relatively simple changes that could be achieved relatively quickly. The challenge, though, is coming up with the political will to do this. And my hope is that policymakers will actually think about how many people rely on this market and find that failure is not an option and find these types of solutions. Thank you for your time today.
Thank you so much, Kris. We're going to turn now to hear a state perspective on this topic, and we're so pleased to have Jessica Altman, who was recently appointed Acting Insurance Commissioner of Pennsylvania on August 19th of 2017. Prior to this, she served as Chief of Staff for the Pennsylvania Insurance Department alongside former Insurance Commissioner Teresa Miller beginning in June 2015. She also has experience at the federal level, having worked at the HHS's Center for Consumer Information and Insurance Oversight. And we're pleased she's with us today to share a state insurance commissioner's perspective on stabilizing this market. Commissioner Altman?
Thank you so much, Catherine. And really, as we always say in health policy, once you know one state's perspective, you know one state's perspective. So I will call this a Pennsylvania insurance commissioner's perspective on the individual market. I'm not sure I have the ability to move slides forward, but what I'm hoping to cover today is a little bit about what we are already doing at the state level to try to contribute to stabilization and how we dealt with those issues for the 2018 plan year, and then a little bit about how we as states, or at least as Pennsylvania, have thought about some of the proposals and evaluated proposals for stabilization and what we've made priorities that we have advocated for and will continue to advocate for as discussions move forward. So in terms of 2018, Pennsylvania was in a unique position. We did approve significant rate increases for 2017 because, as Kurt indicated, we did believe that our market was significantly underpriced and we needed to make an adjustment to get to appropriate prices. And we believe that we did do that. And I think if you looked at our initial rate filing that we received at the beginning of the summer, we had done that, and we would have seen a 8% statewide average increase, which between in medical trend and the new health insurance premium tax was about where we would have expected to be. Of course, given the uncertainty and the non-funding of cost-sharing reductions, we ended up approving a 30% increase. I also think throughout that process, as many of you know, states are where the rubber really meets the road on these issues. State regulators are the ones negotiating rates with insurers, talking about products, and really I view it as my responsibility to make sure that Pennsylvania in 67 counties, and all of our counties here in Pennsylvania, continue to have access to individual market coverage. And while we did not struggle with Adair County here in Pennsylvania, it was certainly more of a challenge to ensure that we avoided that issue this year than it has in past years. And so we did end up, similar to other states, accepting a second filing that would account for non-payment of cost-sharing reductions, and also, which Kurt touched on as well, account for some uncertainty about what might happen to the risk pool given the lack of certainty around enforcement of the individual mandate, perception of enforcement of the individual mandate, and how that might impact who enrolls in coverage and the cost seen in the individual market. We also spent a lot of time thinking about how we would account for the lack of CSR funding and rates, and really believe that the way that we did it, and it's the way that many states did it, would mitigate any negative impact on consumers as much as was possible given the circumstance. And in particular, we instructed all of our insurers to load that cost onto only the price of on-exchange silver plans, which is resulting in significant increases in the subsidy available to eligible individuals, and really increasing their purchasing power, particularly relative to other metal levels of coverage on the exchange, and seeing gold plans that might be similarly priced to silver plans, and bronze plans that for some may be available at $0 premium. I think the second piece of what we did is really, when I think about this market, we've talked a lot about the subsidy structure in this market already on the webinar, but the population I worry about are those who do not receive subsidies, and those who will face the full cost of coverage through the monthly premium, which in Pennsylvania, I think this is pretty close nationally, is about 1 in 5 or 20% of marketplace enrollees. We worked with all of our insurers to make sure that there was an off-exchange only version of silver plans that would not have the disproportionate increase resulting from the CSR, to ensure that there was perhaps a more viable option for that population. So all of that work that we put into providing at least the best options that we could for our residents created a lot of opportunity, but it also created a really big challenge in terms of making sure consumers understand what is happening in the market, understand their options, come in and shop for coverage and explore. And that's really been our focus since open enrollment began on November. Combined with the lack, and this was also referred to, of federal resources being dedicated to outreach and enrollment activities, the cut in advertising, the cut in the Navigator funds, certainly the shorter open enrollment period altogether is contributing. And so we have responded by running our own outreach campaign, and certainly the resources of the Pennsylvania Insurance Department are not comparable to those of the federal government, but we do have paid advertising on TV, radio, social media, some in Spanish here in Pennsylvania. Working strategically with partners, insurance companies, healthcare providers, consumer advocacy organizations, elected officials to get the word out. And we have also made our own plan compare tool available, partnering with Consumers Checkbook, which has been really critical for that unsubsidized population, to give them a place where they can really comprehensively compare all of the options available to them, including those off-exchange only plans that can't be found on healthcare.gov. So these are a number of the ways that states have already been, and Pennsylvania certainly has already been trying to counter the uncertainty and try to make, ultimately my goal is to try to make the state a source of stability, a source of regulatory stability. We don't want to have any surprises at the state level, because we're really having enough surprises at the federal level to go around. So In terms of how we are thinking about or have thought about some of the proposals we've seen in Washington from a state perspective, some of the most critical pieces are operational. Will we have enough time? Will we have adequate and sustainable federal funding for programs? Will we have effective and efficient implementation pathways? And then states really differ in their perspective on this, but I am a firm believer in having a federal backstop for consistency and having a backup plan in certain situations, as we've seen with ACA implementation, where there is federal fallback. In many cases, states aren't always able to take steps forward, and having that backstop, I personally think, is critical. We also, this really gets to the core of the question, what does state flexibility really mean, or at least what should it mean? I think the fear states have had looking at some of the federal proposals, particularly if you look at the funding structures, is that it wouldn't give us the flexibility to do a better job of providing coverage, which is what states want, but depending on the structure of the funding, it would really just give us the flexibility to figure out how to do less and mitigate negative impact of that. And so that gets into trade-offs of who you can cover, what you can cover, how much you can cover, and some of those critical questions that quite frankly, a lot of states are not excited about having to make those tough decisions. In terms of some of the specific proposals we've seen and thinking about the framework that I just talked about, I have a slide here that you can see that has Graham Cassidy and also Alexander Murray, which are two very different proposals. Red certainly indicates areas where at least our state is very concerned. Green indicates things that we're certainly supportive of in the Alexander Murray proposal, and we've been proud in Pennsylvania. Governor Wolf, our governor, has worked very closely with a group of bipartisan governors to try and identify common sense bipartisan solutions that are in many ways incredibly aligned with the Alexander Murray proposal. And in black are sort of areas where it may depend on how it's done. And I'll note that the only reason that the state lines here is black, because that is something that I certainly have concerns about, is that in the Alexander Murray context, it assumes the construct we have today where it is at a state's deference to enter into a compact with another state if they want cross-state sales and work through the consumer protection issues, the regulatory issues at the state level. And I think if a state wants to pursue that of their own accord, that's great. It's when the federal government sort of says you have to do it whether you like it or not where I begin to get concerned. So that's why that one's black and not green. I think also if you go back to those operational issues I was talking about with time and funding and implementation pathways, Graham Cassidy certainly had a lot of concerns about funding, perhaps strongly in the Medicaid space as well as the individual market space, and how those two might play together or play against each other under the funding structure that was really very flexible, as well as the timeline that would have given states just 2 years to figure out how they want to redesign their system and implement a new system. So those are certainly concerns at the state level that we had. Moving on from the congressional proposals, and obviously there have been more than the two mentioned, but I think those provide a good example of the spectrum that we've seen in the proposals. There have been a number of executive actions, and I'm not going to talk about them long because I think others have covered them, but the non-payment of CSRs and the impact of that. We also have very significant concerns about the executive order and the impact that the uptake of non-ACA compliant plans could have on the overall risk pool and the options available to consumers, certainly a concern at the state level. I will note the 2019 Notice of Benefit and Payment Parameters also, it had some interesting stuff in it and perhaps really some flexibility that states were hoping to see. There are some states who are probably going to look very closely at the essential health benefits flexibility. I think the flexibility with the SHOP program is likely appreciated by all. So actually not a lot of concerns here with what was in that notice. In terms of our states or Commonwealth priorities for stabilization, we have certainly been an advocate for the certainty around CSR payments. I would certainly add that we have to think a lot about if something were to happen in the midst of 2018 and how we would deal with that. Robust enforcement of the individual mandate or other incentives that will get people to purchase coverage and bring more people and not less into the market. Long-term federal reinsurance program or state stability funding, streamlining 1332 waiver processes, and I think this one has really become even more important in the last year as we've seen perhaps approvals or disapprovals of waivers at the federal level that it's not always clear precisely what the criteria are for a waiver that is acceptable to the current administration versus a waiver that is not acceptable. And states are going to be looking for clarity, looking for ways to standardize waivers and make sure that if we're going to invest a lot of time thinking about ways to address these issues at the state level, that we're going to get the support and the partnership from the federal government that we need to drive those changes forward. So flexibility to make targeted changes to stabilize the market, perhaps looking at ways the application process can be more efficient, all really good things and important things from the state level. I'll just add that overall, I think states feel like we need to stabilize the regulatory environment at the federal level so that we can stabilize the regulatory environment at the state level relative to that. And certainly we'd like to shift the focus to how we can comprehensively address healthcare costs and try to get more quality into the system and that broader conversation. Here in Pennsylvania is a couple of examples of that. We're having conversations about transparency into costs, both in all-payer claims database on the insurance claim side, also conversations about transparency into pharmaceutical pricing, which I know we've seen California and Vermont take recent steps towards. And we're also trying to really focus on pocketbook issues that are hitting our consumers really hard. The surprise billing and invisible provider issue is one that a number of states have taken action on and that we're currently working on in Pennsylvania and hoping we currently have bipartisan support for that and are hoping to drive that forward because that is an issue where consumers really are doing the right thing and getting harmed by it. And for those not familiar with the issue, I assume many are, this is where a consumer seeks care at an in-network facility or with an in-network provider and sort of not knowing receives some care from an out-of-network provider and is charged with either the full cost or a significant cost for those services. So I'm a firm believer that in these cases where consumers do the right thing, they deserve to be protected, and also really a firm believer that these are the types of issues that we should be dealing with, should be trying to fix, and hoping that we can get some broader stability in the market so that we can have these conversations moving forward. So with that, that is the end of my presentation, and thank you everyone for listening.
Thank you so much, Commissioner Altman, for those remarks, and especially your closing remarks that even expand beyond the scope of our webinar today and are very important. Our final speaker today is Ova Kroy, who's president of the Foundation for Research on Equal Opportunity, which is a nonpartisan, nonprofit think tank that conducts original research on expanding opportunity to those who least have it. He's also the opinion editor at Forbes and the author of Transcending Obamacare, a patient-centered plan for near universal coverage. He also serves on the advisory board of NIHCM Foundation, and we're so pleased he's with us today to share his perspective. Ova?
Thanks, Catherine. Before I start, I should mention that one of my colleagues on the advisory board, Uwe Reinhardt from Princeton, has passed away last night, so I and everyone else, I'm sure, want to pass on my thoughts to his family and say how much he'll be missed by myself and I think many other people on this call. What I wanted to talk about today in a complementary way to what we've heard about from everybody else is to kind of go back a little bit historically. I think we understandably focus always in the policy world on what's right in front of us, what's upcoming. And when it comes to the stabilization of the individual market, we have a conversation about CSRs. We have a conversation with things that are that are hot today, and we tend to neglect the fact that the instability that we've had in the individual market didn't start in 2017. It started in the fall of 2013 when we started enrolling people for the 2014 plan year because that was the first year that the ACA's regulations went into place. So I want to kind of discuss in a more broad way, or a more holistic way, the various ways in which the individual market has been destabilized and what we can do to try to improve that stabilization so that we're achieving the twin goals of making health insurance, or shall we say the triple goals of making health insurance affordable in the individual market for people who are sick, people who are poor, and people who are neither of those things, but also need coverage. So one element of how the individual markets evolved over the last 4 years is that enrollment in the ACA exchanges has been significantly short of what the Congressional Budget Office projected in 2010. So what this chart is showing you is the various projections from the CBO. The most recent one isn't in this slide, but the most recent one that revises even further downward from 2016 has enrollment in the exchanges peaking at about 12 to 13 million. But in reality, we've seen much lower enrollment than what the CBO projected. There are some who argue that this is because there's been unusually high employer-based coverage. My view and the view of others is that's not actually what we've seen. If you actually look at where the differences between the CBO's original projections and the results and the reality, the real world effects today, the vast majority of the difference isn't coming from unusually high employer-based coverage numbers, but rather simply because the individual market has gotten so expensive that a lot of the people who CBO expected to enroll haven't enrolled. And so why is that? Well, first of all, of course, I'm not telling you anything you don't know to say that premiums have increased in the marketplace. I think one thing that I'm trying to illustrate in this slide is that they've increased across age groups. So despite the fact that you have the 3-to-1 age bands, which in theory should mean that all things being equal, people who are in their, say, 60s, early 60s have an advantage relative to the old system, that hasn't actually been the case because of a lot of the adverse selection and other elements of the benefit changes that the ACA imposed. So if we look at what actually drives those changes, I think one thing you hear, and I'm sorry these numbers are a little small on this slide, and we'll try to make them available later so you can take a look at them more closely. But here's an example of a plan from Kaiser in Sacramento, California, and I think the thing I'm trying to point out here is that what you'll hear people say is, well, the reason why the plans are so much more expensive in the post-ACA environment is because the coverage is better. The coverage is more financially generous, it covers more things, et cetera. So what I'm showing you here is two plans that are nearly identical, one from 2013, one from 2014, issued by Kaiser. And what you'll see here is if you can make out the numbers, the provider network is actually the same. So unlike a lot of plans where the networks got narrower in response to the ACA, here you have a plan because of the integration in Kaiser. You have a plan where the provider network is identical in the 2013 and 2014 markets. The actuarial value is almost exactly the same. It was 60.5% for the 2013 plan and 60.4% for the 2014 plan. And the deductibles and benefits were pretty much the same with the important exception of prescription drug coverage, where there were some differences that probably amount to, let's call it, a 5 to 10% difference in premium value for an individual who's signing up for that plan. But as you can see, the premium in the 2014 plan is more than double what the 2013 plan was, despite the fact that in terms of the otherwise what the structure of this plan is, it's basically the same as the plan in 2013. The point being that there are a lot of ways in which the ACA changed the insurance market that for a lot of people didn't meaningfully change the quality or financial generosity of the coverage that they purchased. It simply made it more expensive. I'm going to go to another slide here, which is another way of thinking about this, and this comes from a study that Milliman did, and this looks at the state of Wisconsin. So why Wisconsin? Wisconsin is a state that you can say had kind of the typical regulatory structure of a pre-ACA state. So as you all know, or as many of you know, there are a handful of states in the pre-ACA world that had guaranteed issue, that had age bands, things like that, the New York, the Massachusetts, et cetera, but the majority of states did not, and Wisconsin is one of those states where there was a real difference between the pre-ACA and post-ACA environment. What this slide is showing you is Milliman's analysis of what the drivers were, estimates of what the drivers were of premium increases in the 2014 versus 2013 environment for a 27-year-old healthy male and a 57-year-old unhealthy female, so you can get some visibility into how the ACA affects different actuarial populations. And the point of this slide is to show you that there's a perception out there that the real drivers of the higher premiums in the ACA were guaranteed issue and community rating by health status, and that's kind of something that's come out of a lot of the media coverage and political commentary, in which, because guaranteed issue and age and health status based community rating were politically popular, those were things that were emphasized as features of the ACA. But if you actually look at what's happened actuarially, the impact of those provisions, it's there, but it's not as significant as, in particular, the 3-to-1 age rating. 3-to-1 age rating, and to a lesser degree, 1-to-1 gender rating, but particularly 3-to-1 age rating, was a significant driver of premium increases for the younger half of the eligible population. It's important to remember that prior to the ACA, a majority of those who were uninsured were under the age of 40. The vast majority of people who are uninsured in general are younger and simply have lower incomes, because younger people tend to have lower incomes than older people because they're earlier in their careers and have lower earning jobs. And so when the ACA introduced 3-to-1 age bands, it made insurance a lot less affordable for a lot of people in the younger age brackets, and that's been a big driver of adverse selection. There's a degree to which the actuarial value mandates, in particular, and to a lesser degree EHB mandates, played a role. EHB mandates, gets talked about again a lot, but the impact actuarially is not that large, particularly because most of the plans at the state level had a lot of EHB mandates to begin with. So where the federal mandates differed from the state mandates is relatively incremental. But actuarial value was a big driver of higher costs in the post-ACA market versus the pre-ACA market. So the median actuarial value in the pre-ACA market nationally was about 40 to 45%. And obviously in the ACA, with the way that subsidies are keyed to the silver plan, for most people that became 70%. And so all things being equal, when you go from a 40% AV to a 70% AV, you're obviously dealing with a pretty significant increase in premiums. So yes, there is some impact from health status rating and a few other factors, but really a much more manageable impact. So all this to say that if the ACA's regulatory reforms merely consisted of having 1-to-1 health status rating, say 1-to-1 gender rating, and guaranteed issue, the impact on premiums and the impact on the stability of the market and adverse selection would have been much more modest than it actually was. The two biggest drivers of instability and adverse selection were the 3-to-1 age rating and the significant shift in the median actuarial value of the plans that were being issued on the ACA exchanges. And what we see as a result of that is pretty straightforward. So this next chart comes from data that Avik Health put together, and what you're seeing here, and the dark bars are the 2015 plan year, the lighter bars are the 2016 plan year. What you're seeing here, and this is based on ASPE data, HHS data, the percentage of people who are eligible, subsidy eligible in a given income bracket, how many of those people have signed up for coverage on the exchanges. And what you see is for people who are at near the poverty line, for whom their premiums are almost entirely covered by the premium tax credits, they're enrolling. The vast majority of those individuals are enrolling. But as you have that sliding scale where the subsidies decrease as you go up the income scale, there's a much, much less enrollment. And what that's telling you is that the impact of all these regulatory changes and the degree to which it increases premiums is having a huge effect, particularly as you get above 200 to 250% of the federal poverty level, and particularly over 250, because as many of you know, over 250 of FPL, you're not eligible for the cost-sharing subsidies, which is another thing that makes the exchange-based coverage attractive for people below that threshold. And so this is a big problem. If the goal of the ACA and the goal of health reformers in general is to make sure that everybody can afford health insurance, we're doing a reasonably good job of making sure that people around the poverty line can afford health insurance. We're doing a reasonable job of heavily subsidizing coverage for people who are really sick, who have really, really high medical costs, because we have guaranteed issue and tax credits. But for pretty much everybody else, we're seeing higher premiums. And of course, obviously, once you get above 400 FPL, as was illustrated earlier, we have a big spike in the out-of-pocket costs that those individuals are exposed to. So let me again step back a little bit more and talk about this conceptually. So back in the run-up to the passage of the ACA, we had a number of people talk about the three-legged stool, right? The idea that you had to have the balance of the regulations, the subsidies, and the individual mandate. All three of those had to be included in the ACA in order for the individual market to work. Why is that? Because the market reforms would drive up premiums. The subsidies would defray the cost of those premiums for some people, and the individual mandate would force the younger and healthier people whose premiums are doubling or tripling back into the market when they face those higher premiums, and otherwise a disincentive to enroll. So that's in theory how the ACA was supposed to work, but in that run-up to the passage of the ACA, there was not enough discussion of the engineering problem of, okay, it's a great metaphor, the three-legged stool, but in order for you to be able to sit on a three-legged stool, the different legs of the stool have to all be the same length, and they have to have the same angle to the ground. Imagine if you had a three-legged stool in which all three legs of the stool were of different lengths. That would be a hard stool to sit on. And that's basically what's happened with the ACA, is that the three legs of the ACA stool are of different lengths, which has made the stool unstable. So the way I would torture the metaphor of the three-legged stool is to observe that the adverse selection that we've seen due to the regulatory change of the ACA are very, very significant. So that's the longest leg of the stool, you could say. Whereas the subsidies are sort of are kind of in the middle. The subsidies do a partial job of defraying the impact of the adverse selection for, again, particularly those people near the poverty line who get the full benefit of the subsidies, but they don't completely defray the cost, particularly for those whose incomes are in that upper range of the 100 to 400 FPL bracket. And then the third stool, the shortest stool, is the individual mandate, which is very weak. It has a lot of loopholes and exemptions. There are large swaths of the individual market participating populations that are exempt from the mandate for one reason or another. And so the impact of the individual mandate is far less than is commonly believed. Between the actual design of the individual mandate, it was watered down and weakened a lot in order to satisfy political concerns, and it also has not been enforced aggressively by the Obama administration or by the Trump administration. Actually, the Trump administration has enforced it a little bit stronger to date, though there's been some discussion of changing that. The individual mandate is the weakest leg of the three. So basically, this is, to kind of go back to the three-legged, so this is the basic problem, that if you want to solve the stability of the individual market, regardless of what happens with cost-sharing subsidies and the stuff that's in the news today and the stuff that everyone's talking about today, if you really want to get stability in the market, this rebalancing of the stool is what you've got to try to address. So how would you do that? Well, there are different ways to balance the stool. You could lengthen the legs of the stools that are shorter, the subsidy and mandate legs, or you could shorten the leg of the stool, piece of the leg of the stool that's longer, which is the adverse selection regulation leg. And that maps pretty reasonably to where the kind of political debate is about health reform. So if you look at the menu that would be shorting the adverse selection leg or shorting the regulatory leg, the two biggest targets, as I alluded to earlier, would be to repeal age-based community rating and to reform the actuarial value requirements to give enrollees alternatives to the high actuarial value plans they currently have on the exchanges. So one key element to this particular slide that's really important to understand is how they interact with the means-tested tax credits in the ACA. So as nearly all of you understand, the tax credits in the ACA are key to your income. Depending on exactly where you are in the income bracket, you have a certain amount of your percentage of your income which you're expected to pay to pay for the premium, and anything above that is covered by the tax credit. And the reason why that concept is really elegant and really important, and particularly why it's really elegant and really important, is it actually makes a lot of the regulations in the ACA redundant. So imagine if you're somebody, if you repeal 3-to-1 age bands and you have somebody who went back to 6-to-1 age bands, say, de facto in the marketplace. And so in theory, all things being equal, again, you would expect that means that maybe someone who's 62 years old would pay a higher premium. But actually, if they're below 400 FPL, they wouldn't pay a higher premium because that increased cost would be absorbed by increases in the amount of premium assistance they would receive under the ACA. Not only that, you'd have the fact that because you'd have a lot less adverse selection because younger people would be more incentivized to enroll, you'd have a situation where actually overall average premiums could go down because you'd have a better risk pool, right? So the key thing to understand when it comes to regulatory reform is the way it interacts with the elasticity of the premium assistance, such that you can actually do a lot to lighten up on the regulations and have the direct subsidies in the tax credit piece do more of the work of defraying the cost of coverage for actuarially high-risk individuals. So this gets to the point in this slide, right? So the key thing, in my view, is to preserve the means-tested structure of the ACA tax credit. As we went through the last 12 months on the Republican side of what Republicans wanted to do to replace the ACA, there was first of all, there was a big debate about whether refundable tax credits were a worthy vehicle at all, and then there was the debate between the House and the Senate as to whether or not tax credits should be flat, irrespective of income, or whether they should have a structure that kind of echoes the ACA's means-tested structure. And the Senate settled on the means-tested structure, which I think is an important area of bipartisan agreement now, that means-tested tax credits are the right vehicle for ensuring that uninsured individuals can afford coverage. Because, again, it gives you a lot more flexibility on the regulatory piece to make sure that you're doing what you can to get younger and healthier people in the pool. One thing that the Senate Republican bill did that was very interesting that alludes to something that was said earlier is it harmonizes the relationship between age and income in the tax credits themselves. So under the ACA, the tax credits purely adjust based on your income, but in the way the BCRA did it is it has a combination, a hybrid model where you'd get more premium assistance not only if you were of lower means income-wise, but also if you were younger. So in order to kind of compensate for the fact that the regulatory structure in the ACA is geared towards favoring older and sicker individuals and disfavoring younger and healthier individuals, the subsidy structure in the BCRA was designed to compensate for that by providing a little bit more assistance with lower income thresholds before the tax credits kick in for younger individuals as a way of getting younger people enrolled in the pool. Another idea kind of bringing us to the current day in terms of the cost-sharing subsidies ideas. Of course, there are lots of ways to simply kind of appropriate the money for the cost-sharing subsidies and continue with our regularly scheduled programming. In my mind, there's an opportunity to convert the cost-sharing subsidies into HSA deposits that enrollees would control as a way of defraying their deductibles and copays. There's some technical things that, in this short period I don't have the time to go into in terms of how you would design that, but that might be a way of providing a bit more of consumer engagement in the way that lower income people who are currently eligible for the cost sharing subsidy benefit are able to utilize those dollars and roll them over time. So what's the right approach in terms of dealing with the individual mandate? We've heard arguments today from Kris and others that the individual mandate's important to preserve, that there aren't really any adequate replacements for the individual mandate. And I think that would be a stronger argument if the individual mandate were robust in its design and its implementation and its enforcement. But there isn't a lot of evidence that the individual mandate is having a significant effect on market behavior up to this point. And there's been a fair amount of research now on this, which concludes that the individual mandate is not really driving enrollment in the exchanges or in other parts of the market where the Congressional Budget Office believed the individual mandate would be having a significant effect. And obviously, from an ideological standpoint, there are a lot of people who are concerned on the right that the individual mandate is, whether you think of it as a constitutional injury or just a bit intrusive from a standpoint of the government's role in the individual market. Those arguments, to whatever degree you believe in them or not, they are certainly still strongly held in conservative circles. So the question, I think, is there a viable alternative to the individual mandate that would achieve the same goal of making sure that you don't encourage adverse selection, you have perhaps, you limit the ability of people to jump in and out of the market, but you actually do the things you need to do to have a stable risk pool. And there are ways to do that. And so in this slide, I've listed a number of different bullets of what you could actually do without an individual mandate, because, again, the individual mandate in the ACA, it has to be emphasized, is so riddled with loopholes and exceptions and exemptions and is so weakly enforced by the IRS that it effectively doesn't exist. And so there actually could be an improvement on the status quo in terms of encouraging people not to game the system and getting involved in the marketplace. If we did things to limit our ability to game the system like we do in Medicare, we don't have an individual mandate to enroll in Part D or Part C, and yet we have a lot of mechanisms that we use in Part C and Part D to prevent people from jumping in and out of the system. All we have to do, really, to oversimplify, is borrow from what we do in Medicare C and D to have a better system, a more stable system than what we're doing right now in the real world with the ACA individual mandate. A number of people have talked about auto-enrollment as an alternative to the individual mandate. My personal view is that I'm not persuaded that we've surpassed the technical considerations to make auto-enrollment a thing, especially if you maintain a means-tested tax credit in which the tax credit is the amount of financial assistance and the net premium to an individual is varying a lot. How do you actually auto-enroll someone in a plan unless you know exactly what the impact of them in terms of what premium they're going to be expected to pay? If someone really smart has figured that out, I know there are people out there who write about this. I'm certainly open to the idea, but I haven't been persuaded that those technical challenges have yet been met. Let me see if I got the right slide here. Oh, yeah. Okay, great. So what I'm describing, I think one thing I want to emphasize is that the goal of a regulatory structure of the kind that I've just described is to actually try to get more people into the market, to get to that original CBO projection where we have 25 million people enrolled in the exchanges as opposed to 10 million. If paired with a bunch of other reforms that we talk about in our main health reform white paper, Transcending Obamacare, using CBO-style microsimulation analysis, we find that this combination of reforms could lead to 12 million more people having health insurance on net than do today, because the premiums would be lower and the benefit package would be more attractive to a broader range of people, while still, again, ensuring that people with high health costs, whether it's because of health status or their age, would still have the financial assistance they need to afford coverage. For those who are interested in learning more about these ideas or reading about them in more detail, I encourage you to go to the website of our think tank, FREOPP.org, FREOPP.org, where you can download Transcending Obamacare, and I'm happy also to take any questions either now or later. My email address is aroy@freopp.org. Again, that's FREOPP.org. Thank you very much.
Thank you, Avik, and thank you to all of our speakers. And we're going to jump into our Q&A, and you can continue to submit questions online. I wanted to start with a question and also allow the other speakers a chance to reply to Avik's comments on the individual mandate. This question is, how would your projections about the future risk pool and estimates about the amount of money needed each year to stabilize the market change if Republicans do repeal enforcement of the individual mandate as part of tax reform as is currently being considered? Kris, do you want to start?
Sure, thank you. So I do agree with Avik that the value of the individual mandate has declined somewhat over time, in part because the premiums have become so expensive. So today, that the mandate penalty for most people is equal to about a month and a half worth of premium, which, I don't think most people would view as a significant incentive to buy insurance, given where the costs are now. But eliminating the mandate, will have an impact on the market, and Kurt, I'm sure could expand on this, but as I talk to other actuaries, they still feel like it's probably worth 10 to 12% of premium, even as it currently exists, without the type of robust enforcement that folks in the industry might like. So I think if we take this out, it will have an impact on the premiums that have been set for 2018. It could have an impact on the future prices for 2019. And I think it would really be a shame to eliminate the mandate if it's not coupled with some other significant changes to the underlying rules that exist in the ACA, and most importantly, coupled with the type of reinsurance mechanism that I think everyone has supported on this call.
Kurt, do you want to respond as well?
Sure. I'll just amplify that a little bit. I think that first, repealing the mandate would send an unfortunate signal to the market that you no longer have to have coverage. I think just that signaling is important, and repealing it could have pretty serious negative impacts. And then when we think about some of these levers, or I don't really know what the right phrase to use here, but these interventions we'd want to make to try and get people to participate more actively, so the, continuous coverage type provisions, that's really a difficult thing to say to somebody who's deciding whether or not to participate in the market, that, boy, if you don't do it now, in a year from now, you may be subject to some penalty. And that person is probably thinking, well, a year from now, I might have coverage through some other means. I might get employment, or I might qualify for Medicaid. There may be other means. And then a year from now, I may not want insurance anyway. So our view is that these kind of continuous coverage provisions just don't have the same sort of teeth that the mandate could have, and does have actually, or particularly though could have, if it were better publicized and better enforced. So I think the presence of the mandate is a pretty important thing for the long-term health and stability of this market.
Kris, did you want to have something else to say?
Oh, I was just going to mention that there was a letter sent by a major provider, physician, hospital, as well as health plan trades today to the House and the Senate, encouraging them to not eliminate the individual mandate penalty as part of tax reform this year. We really do think this would have to be thought of in a much broader package of reforms in order to not have a negative impact.
Great. Thank you. Another question we mentioned briefly today, these short-term policies. What will the impact be of allowing short-term insurance up to 364 days as suggested by the Trump administration? Do we know how large the short-term duration insurance market is, and how large was it prior to the Obama administration limiting this coverage to only 3 months?
It's Kris. I can start this, and I know others have looked at this too. But when you look at filings with the National Association of Insurance Commissioners, the market that's filed as short-term limited duration coverage today is about 160,000 lives. In 2014, it was about 144,000. So it's a very, very tiny piece of the market today. When we look at the future, though, I think it could be a much bigger piece of the market because most of the major insurers that have been offering coverage in the individual market have pulled out of the market now and may view this as an alternative market. I think this policy reversing the current limitation on these policies, which limits the duration of these plans to 3 months and prohibits the policies from being strung together to substitute for major medical coverage, could have a really negative impact on the traditional individual market, in part because it would operate under completely separate rules. The coverage is fully underwritten. It can include lots of exceptions. One of the major marketers of this coverage today includes 54 exclusions if you're even offered one of these policies. And it's not renewable to the consumer, so it can be re-underwritten, and actually new policies are issued every time the term expires. So it's hard to see how that market can coexist with the traditional comprehensive market if it really is allowed to be offered on a 364-day basis.
This is Jessica. I would just add a couple of things, agreeing with everything that was just said. First, as I think it also may depend on the combination of things that happen. So, for example, if the individual mandate were to go away, I think that would certainly exacerbate the potentially negative impact of the growth of the short-term limited duration plans in the market space, because even if the plans are accurately marketed, one of the big downsides today is even if you buy that plan, you may still face that penalty. And so if that were no longer the case, I think that could change the equation significantly. And then I think the point on marketing is pretty huge, and then we could see more interest in getting these plans out into the market in the future, and we have actually already seen that both in terms of accurate marketing, but also unfortunately in terms of inaccurate marketing, and that's something that Pennsylvania has been very active in if there are cases of misrepresentation, but it's something that states will have to really look out for in the future if these rules change, and really if they don't.
This is Avik. I think that the potential for growth of short-term limited duration plans is pretty significant. Again, it's been a small market, as has been noted in the past. The rules that the Trump administration put in place earlier this fall were basically the same rules that had existed for most of the history of short-term limited duration plans for 7.5 of the 8 years that Obama was in office, for example. It was only really in the second half of 2016 when the rules were changed as there was became more awareness of how more people were using short-term limited duration plans as an escape valve from the higher premiums under the ACA. I would expect the awareness of STLDIs as an option to increase. We're seeing an interesting kind of bifurcation of the market where Blues in particular are committed to making the exchanges work, really focusing on the broader individual market, and you're seeing other players like United Health focus on the short-term limited duration plans and not be involved in the individual market. So that I think is going to be interesting to observe if the insurers who are not in the individual market today spend more time looking at the STLDIs if the rules that are now in place continue to be in place. And I do think that one thing that the STLDIs do politically is they remove, in a sense, some of the pressure to to reform the regulatory structure of the ACA. That is to say, effectively, for all the kind of kludginess of it, you end up having a market where the premiums are lower and underwritten for those who want that, and the premiums are community rated and subsidized for people who want that. And for some people out there who yearn for a return to the pre-ACA system, that's an attractive result of this regulatory change.
Great, thank you. We've had several questions come in from sort of a consumer perspective for those that aren't qualifying for subsidies, and sort of what's your advice to these consumers who are finding their plans to be very expensive for next year? They're not subsidized and they're struggling to figure out the most affordable plan. And are there any recommendations for what we can do about that going forward?
This is Avik again. I mean, in terms of the cost-sharing subsidy piece particularly, in most states, not every state, but in most states, the premium increase that's associated with the lack of funding for the cost-sharing subsidies only affects the silver plan. So if you're in the unsubsidized portion of the market and you buy a bronze or a gold plan, you're likely not to see the same premium increases in those plans that you saw in the silver plan. In fact, the Congressional Budget Office believes that the price of gold plans could decline because of this shift for a lot of people who end up in the gold plan rather than the silver plan. And again, they obviously now have this ability again to go into the short-term limited duration plan. So purely looking at it from the consumer standpoint, if you're comfortable with the short-term limited duration plans, obviously not everyone is or should be, that's one option. But in the kind of what we might call the conventional market now, the ACA market, the gold and bronze plans in particular are likely to be more attractive than the silver plans.
Great. Jessica or anyone else want to weigh in on that?
Yeah, I mean, I agree with a lot of that, but, I think it does depend, and I would recommend if you are a policymaker or an organization to really understand how a specific state dealt with the CSRs, because it is correct that most states did the silver loading and that bronze and gold are therefore not disproportionately impacted, but there are states who did spread the rate increases around differently. And then there are also states who, like Pennsylvania, made sure that these off-exchange-only plans that are not impacted at all by the CSRs and retain the silver level are available. And I think we are unique in that, although I think New Mexico may have this as well, we are an FFM state, but we do have that checkbook tool. But if you're not in a state that has a similar venue where you can compare all of the ACA-compliant individual plans in one place, really the best thing to do if you're looking for potentially off-exchange only plans that might be different and you're not sure if they're there or not is either to speak with an agent or broker or one of the direct enrollment brokers, or call the health insurance company directly or health insurance companies directly. So, but it really depends. Like I said, in Pennsylvania, we've created some really great venues for consumers to really be able to compare all of these options together, although we are not promoting non-ACA compliant plans here in Pennsylvania, certainly.
Great. Thank you. Unfortunately, we are right at 3 o'clock, so we're going to have to wrap up, but I do want to thank our excellent panel of speakers for taking time to be with us today to talk about this important topic. And I'd like to ask our audience to please take a moment to share feedback by completing a brief survey, which can be found on the bottom of your screen. We'll be posting a recording of the event to our website in case you missed any of the presentations, and you can also find copies of the slides on our website. And thank you all again for joining us today.